Now have a look of this question. Which of the following combination is incorrect? Incorrect about renal stone. First, calcium oxalate stone is the most common type of kidney stone. This is correct. Uric acid stone is most common radiolucent renal stone. This is also correct. Xanthine stone is brick red colored, round, and show lamination on cross section. This was asked in NEET once. This is also correct. Cystine is extremely hard, but this is radio opaque. Be careful, this is radio opaque stone. So the correct answer for this question is D. Stones are very important, so we are going to discuss the rest of the questions related to renal stone. Now see, first there is calcium oxalate stone. Now it's very simple. It's very simple to know what are the risk factors for that particular stone. What you do, you just see the composition of the stone. If you see the composition, it is calcium and oxalate. It means this stone is formed in situations where either there is increased level of calcium in blood or urine, or there is increased level of oxalate in the urine. It means what are the risk factor? Hypercalcemia, hypercalciuria, hyperoxaluria. So these are the risk factors for calcium oxalate stone. It is the most common type of renal stone, and one simple principle is there. The stones which are having calcium as their major component, those stones are usually radio opaque. So this calcium oxalate stone is obviously radio opaque. It's the radio opaque stone. Second is uric acid stone. Uric acid stone. Now simple question. In which case there is formation of uric acid stone when there is hyperuricemia? So what are the risk factors? Hyperuricemia, gout, Leach-Nyhan syndrome, and whenever we give chemotherapy in cases of malignancy because of rapid turnover, there is increased risk of hyperuricemia leading to uric acid stone. Uric acid stone is radiolucent. This is radiolucent. This is the most common radiolucent stone. So it's most common radiolucent stone. Now see how there is formation of uric acid. There is hypoxanthine. This hypoxanthine is converted into xanthine, and this xanthine is converted into uric acid. It means in the treatment, what are the options which are given in the treatment? See, basically in cases of renal stone, first principle is we have to dilute the urine. That's why in all kind of renal stones, first principle is plenty of fluid should be taken. Second, we have to see the composition of stone. If stone is acidic, we have to go for alkalinization of urine, and if the stone is basic, we have to go for acidification of urine. Why? Because acidic stones are going to precipitate in acidic urine, and the basic stones are going to precipitate in basic urine. But if we are going to alkalinize the urine, what will happen? Acidic stone will combine with alkali, and there is formation of salt which is soluble, and that will be excreted in urine. So here, since it's uric acid, we can go for, apart from plenty of fluids, we can go for alkalinization of urine, and we can use one drug which can block both of these steps: conversion of hypoxanthine into xanthine and xanthine into uric acid. And what's that drug? The drug is allopurinol. The drug is allopurinol. So this allopurinol is used in uric acid. Third stone is triple phosphate. Triple phosphate stone. What's the other name of this triple phosphate stone? It's also known as Staghorn calculi. Staghorn calculi. What is the other name? It's calcium, magnesium, ammonium, phosphate. So the other name is calcium, magnesium, ammonium phosphate. Now this triple phosphate stone is more common in females. So why it's more common in females? Because in females there is increased risk of UTI. Why in females there is increased risk of UTI? Because of short urethra, and that's of 4 centimeter. There is one organism which produces urease. What's that organism? Proteus. Proteus produces urease, and this urease is going to convert what? Urea into ammonia. It will convert urea into ammonia, and you can see here that this ammonia is precipitated with calcium, magnesium and phosphate, leading to formation of triple phosphate stone. Now this staghorn calculi or triple phosphate stone, can you see, this is minor calyx. There are 3 to 5 minor calyx. The stone is very large. It is so big that it is going to fill the pelvic calyceal system. And if I am going to take out the stone, can you see the shape? The shape of stone is something like this, and there is branching in the stone. And because of this branching in the stone, branching like horn of stag. So because of this branching, it is known as what? Staghorn calculi. It causes silent destruction of kidney. Second problem, stone is so big that a single technique is not sufficient to remove. That's why generally we use sandwich technique. Here, for the treatment, we use sandwich technique, in which we use PCNL plus ESWL for the treatment of triple phosphate stone. Fourth is cystine stone. Now see, the composition is cystine. It is seen in cystinuria. It is seen in cystinuria. I told you, if in the stone there is calcium, it's radio opaque usually. Here, what is the problem? There is no calcium, but there is a bond, that is double sulfur bond. So in this stone there is double sulfur bond, and because of this double sulfur bond, this is what? Radio opaque. This is radio opaque. Second, it's very hard, not easily broken by ESWL. Not easily broken by ESWL. Now second problem, it's a metabolic disorder, cystinuria. That's why if we are using some complexing agent, that complexing agent is going to bind with cysteine, and what will happen? It is going to decrease the incidence of cystine stone. What are those complexing agent? The preferred one is alpha MPG. Full form, alpha mercapto. It's alpha mercapto propionyl glycine. So alpha mercapto propionyl glycine. And the second one is D-penicillamine. D-penicillamine. This D-penicillamine is less preferred. Preferred agent is alpha MPG. Why D-penicillamine is less preferred? Because of side effects. The patient is not going to tolerate the side effects. So preferred agent is what? Alpha mercapto propionyl glycine. Fifth is xanthine stone. Xanthine stone, and this xanthine stone is seen in xanthinuria. You can identify this stone by its color. It is brick red in color, and this stone shows lamination on cross section. It shows lamination on cross section. This is radiolucent. Now again see the simple cycle. There is conversion of hypoxanthine into xanthine, and that leads to xanthinuria. So if you are going to block this step, what? The stones have prevented. So which drug can be used? Same, allopurinol. So here also you can use allopurinol. This is xanthine stone. After that, in pharma, in medicine, in surgery, questions are asked which are related to medicines or drugs which increases the incidence of stone. First, triamterene. Now, this excessive use of triamterene, which is a potassium sparing diuretic, can lead to radiolucent stone. it can lead to radiolucent stone. Next is indinavir. Indinavir. Indinavir is protease inhibitor used in HIV patient, and again it leads to formation of radiolucent stone. After that, silicate stone. Silicate stone. Excessive intake of silica containing antacids. Excessive intake of silica containing antacids leads to formation of silicate stone. So silica containing antacids. So these are the stones. After that, questions are asked, out of these stones which are radiolucent. So there is a mnemonic. Mnemonic is Tiksu. Tiksu is radiolucent. T means triamterene. Triamterene. I means indinavir. Xanthine and uric acid. Triamterene, indinavir, xanthine and uric acid. These are radiolucent. After that, questions are asked which are acidic. Mnemonic is CCU. CCU is acidic. C means calcium oxalate, cysteine and uric acid. So these are the questions which are frequently asked related to the stones. Now this question was asked in a latest exam. See, chronic laxative abuse. Chronic laxative abuse can result in the formation of which type of stone? And the correct answer is ammonium urate. What is the etiopathogenesis of formation of ammonium urate and in which conditions this stone is formed? Have a look. Now conditions associated with ammonium urate stone formation or ammonium acid urate crystallization include, first is chronic laxative abuse, recurrent UTI, recurrent uric acid stone formation and inflammatory bowel disease. Now, what is the etiopathogenesis in the formation of this ammonium urate stone? It is said that it's the result of chronic dehydration. So, any condition in which there is chronic dehydration, and that chronic dehydration causes intracellular acidosis. And because of this, there is enhanced or increased ammonia excretion. And since urinary sodium is low, in the setting of laxative abuse, urinary sodium is low, so urate complexes with abundant ammonia. So here there is urate which is going to complex with abundant ammonia, and there is formation of ammonium urate stone. Simple. Now there is similar pathophysiology in cases of primary bladder stone. In primary bladder stone, which is more common in children of undeveloped countries or underdeveloped countries, they have chronic dehydration, and because of that, in the bladder there is formation of ammonium urate stone. So primary bladder stone is also most commonly ammonium urate because there is dehydration, and in patients of chronic laxative abuse there is dehydration leading to intracellular acidosis. It leads to increased ammonia secretion in the urine, and there is low urinary sodium. That's why urate combines with ammonia in the urine and there is formation of ammonium urate. So for this question, correct answer is ammonium urate. Option is B. Lots of questions are asked related to referred pain in cases of renal and ureteric colic. So see the questions related to referred pain first, and then we will discuss the question. So in cases of renal and ureteric colic, when there is stone, the most common symptom is pain. But be careful, the severity of pain is not related to size of stone. Now, the radiation of pain depends on the location of stone. Now have a look. Suppose this is kidney, this is ureter, and this is the bladder. Whenever stone is located in the pelvis, in the pelvis or upper one third. In this case, there is referred pain. Pain is referred to testis or labia majora. In males, it is referred to testis or labia majora in females. Via which nerve? Via subcostal nerve. It's via subcostal nerve. Now, second, if the stone is located in the middle one third. If the stone is located in the middle one third, pain is radiated. Pain is radiated to iliac fossa, hypogastrium, iliac fossa, hypogastrium, and groin. Iliac fossa, hypogastrium, and groin. Now, simple question. If the stone is on the right side, it is going to radiate to right iliac fossa, and if the stone is on left side, it is going to radiate to left iliac fossa. Now, if the stone is in the middle one third of ureter on right side, it mimics which condition? Acute appendicitis. And if it's on left side in the middle one third of ureter, it mimics which condition? Diverticulitis. Now, it's very easy to remember. Since pain is radiating to iliac fossa and hypogastrium. Iliac fossa and hypogastrium. So what is the nerve responsible? So it's via which nerve? Iliac fossa hypogastrium. So correct answer is iliohypogastric. So it is via iliohypogastric nerve. Now if the stone is located in the distal one third, in this case the pain is radiating to inner aspect of thigh, scrotum, and perineum. Inner aspect of thigh, scrotum, and perineum. Via which nerve? Via ilioinguinal nerve. So this is the radiation. Now, another situation, when the stone started approaching bladder. If the stone started approaching bladder, in that situation, patient will be having bladder-related symptoms like frequency, urgency, and dysuria. Another situation, whenever stone is in the intramural ureter. In intramural ureter, if stone reaches, then patient will be having strangury. Strangury means painful micturition, and urine comes drop by drop, and there is difficulty in passing urine. So this is strangury. Difficulty in passing urine, there is painful micturition with passage of urine drop by drop. Strangury. So these are the questions related to referred pain in cases of stone in the kidney and ureter. So see the question. Referred pain from ureteric colic is felt in the groin due to involvement of which of the following nerve? And correct answer is what? Iliohypogastric. In iliac fossa, in hypogastrium, and in the groin, it is via iliohypogastric nerve. Now similar questions were asked in many exams, that what are the stones which are very hard and not easily broken by ESWL. There are 4 stones. First is bruchite, second is hydroxyapatite, third is calcium oxalate monohydrate, and cysteine. So be careful. All these 4 stones are very hard, not easily broken by ESWL. This question was asked in many exams and the answers were different. Somewhere hydroxyapatite was mentioned, somewhere calcium oxalate monohydrate was given, and somewhere as a correct answer cysteine is given. So all these 4 stones are very hard, not easily broken by ESWL. How to remember? The mnemonic is BHC2. So the mnemonic is BHC2, bruchite, hydroxyapatite, calcium oxalate, monohydrate, and cysteine. So correct answer for this question is A, that is calcium oxalate monohydrate. If you have seen the papers of exams from the last 2 to 3 years, almost every year there is one question related to crystals. So first let us discuss the shape of crystals and then we will discuss this question. Now first have a look of this. This is enveloped bipyramidal or envelope shaped crystal, and it is seen in calcium oxalate. Which particular type? Dihydrate. So it is seen in calcium oxalate dihydrate. This is bipyramidal or envelope shaped. And if you see this crystal, what is the shape of this crystal? It is dumbbell shaped or hourglass shaped. Can you see? It is dumbbell shaped or hourglass shaped, and it is seen in calcium oxalate monohydrate. Now this one is seen in calcium phosphate, and here you can see what is the appearance. It is amorphous, flat shaped plates or wedge shaped prism. So if the shape of crystal is, it's looking like amorphous, flat shaped plates or wedge shaped prism, it's calcium phosphate. Now see this one. In the brushite, there is needle shaped stone. So here you can see there is needle shaped crystals. So these are seen in brushite, the needle shaped crystals. After that, this was asked in many exam. This is coffin lid. So it is like coffin lid crystal, and it is seen in struite stone. Now can you see here? It is hexagonal or benzene shaped, and it is seen in cystine stone. So cystine stones are having hexagonal or benzene ring like crystals, and this is seen in uric acid stone. This is seen in uric acid stone. So in uric acid stone there is multifaceted irregular plates or rosette shaped crystals. So these questions are very very important nowadays, frequently asked. So have a look of the question first. Correct order of stone on the basis of image of crystal. So see, this is bipyramidal or envelope shaped. It is seen in calcium oxalate dihydrate. This one is rosette shaped. It is seen in uric acid. Multifaceted rosette shaped uric acid. This is coffin lid. It is seen in struite. And this one is hexagonal or benzene ring shaped. It is seen in cystine. So which one is correct? These two are incorrect. First is calcium oxalate, second is uric acid, third is struite, and fourth is cystine. So correct answer for this question is B. Now let us first discuss what is ESWL, and then we will discuss the question. The full form of ESWL is extracorporeal shockwave lithotripsy. What do you mean by extracorporeal? Extracorporeal means the shock wave is generated outside the body and then it is focused inside the body. How it works and how it is generated? First, the gold standard lithotripter is Dornier unmodified Dornier unmodified HM3. This is the gold standard lithotripter. Now see how it works. This is the kidney, this is the ureter, and this is the stone. So what? The shock waves are focused in the body and then it is focused on the kidney. Now when it is focused on the kidney, there is change of density from soft to hard. Why? Because in the kidney there is stone. So whenever there is change in density from soft to hard, what will happen? The energy is released at the surface of stone. So it's like we are hitting a stone with a hammer, and if you keep on hitting the stone with a hammer, what will happen? Stone will crack. So what will happen? There is cracking in the stone, and if you keep on hitting the stone further, what? It breaks and shattered. So because of shock waves there is erosion, and after erosion what happens? There is shattering. So stone is fragmented into small pieces. So there is shattering, and after that these small pieces of stone are going out via ureter. So these are the small fragments of stone are excreted outside via ureter. Now the problem, in certain conditions there are obstruction. Suppose there is obstruction in ureter. If there is obstruction in ureter, what will happen? In the proximal part of ureter, there is collection of these stone fragments, and this complication is known as Steenstrasse. This complication is known as Steenstrasse. It is also known as street of stones, also known as street of stones, also known as columnation of gravel. It's also known as columnation of gravel. After that, this ESWL is useful for most of the stones, but the maximum size which can be removed is 2 centimeter. In kidney, maximum size removed by ESWL is 2 centimeter. After that, there are certain stones which are very hard, not easily broken by ESWL, and I told you the mnemonic BHC2, brucite, hydroxyapatite, cysteine, calcium oxalate monohydrate. After that, questions are asked that what are the contraindications of ESWL? Now see, simple question. What are the conditions in which you cannot give shock waves to the abdomen? Obviously pregnancy. And if there is bleeding disorder, patient is having some kind of bleeding disorder, giving shock waves can increase the risk of bleeding which cannot be controlled easily. So question, what are the contraindications of ESWL? Absolute contraindications and relative contraindications. The absolute contraindications I told you is pregnancy and bleeding disorders. It's the pregnancy and bleeding disorders. What are the relative contraindication? First, pacemaker. If patient is having pacemaker because it increases the risk of extrasystole, UTI, distal obstruction, obesity, orthopedic abnormalities, like scoliosis, kyphoscoliosis. What is the problem in scoliosis and kyphoscoliosis? It is difficult to focus the waves on the stone. Uncontrolled hypertension, aneurysm, and renal failure. Uncontrolled hypertension, aneurysm, and renal failure. Clear? So these are the absolute and relative contraindication. Now one simple question. Generally, the conditions in which ESWL is contraindicated, usually those stones are managed by PCNL. Now simple question. If the size of stone is more than 2 centimeter, we are going to manage it with PCNL. There is UTI, PCNL, distal obstruction, PCNL, Staghorn calculi, PCNL, hard stones are there, PCNL. So this is how we manage renal stone. Now have a look of the question. All of the following statements are correct about ESWL except gold standard lithotripter is Dornier unmodified HM3, correct? Steenstrasse is seen in cases of distal ureteric obstruction, correct? Pregnancy is an absolute contraindication, correct? Maximum size of stone removed 1.5 centimeter. Actually, it's 2 centimeter. So you tell me in which condition maximum size of stone removed is 1.5 centimeter. It's in ERCP, and this is for CBD stone. So be careful. In renal stone, maximum size of stone removed by ESWL is 2 centimeter. In CBD stone, maximum size of stone removed by ERCP is 1.5 centimeter. So correct answer for this question is D. Have a look of this question. A patient presents with pain and tenderness in left iliac fossa. Ultrasound shows a 3 centimeter stone in the renal pelvis without any hydronephrosis. So see the situation. In this situation, the stone is where? In the renal pelvis. Here is the stone. What is the most appropriate management? Obviously, diuretics, no role. Medical dissolution therapy with potassium chloride, no role here. Now we have to choose between PCNL and ESWL. Just now I told you what's the maximum size of stone which is removed by ESWL, 2 centimeter. So correct answer for this question is PCNL. This stone will be removed by percutaneous nephrolithotomy. What we do in percutaneous nephrolithotomy? Have a look. Now see what is done in cases of percutaneous nephrolithotomy. You can see that this is kidney. Here This is minor calyx, and this is the major calyx. This is pelvis. Now, what? For first, we have to create a track from the skin to the kidney, and after creating the track, we are going to insert a scope that is known as nephroscope. And which approach is preferred? Yes, it's the calycial approach. So via posterior calyx, we are going to insert the nephroscope. Now what? Whatever the stone is there, this stone is being broken and the fragments are taken out. So here you can see this is the stone. Via this nephroscope, I'm going to break the stone, and whatever the pieces are there, those pieces are removed. So what? Size is not a criteria. Distal obstruction is not a criteria. Hardness is not a criteria. And whenever the stone is being removed via the same track, we are going to insert a drainage tube that is known as nephrostomy. So this is percutaneous nephrolithotomy. Now before discussing this question, have a look that what is ureteroscopy. So you can see that this is kidney, this is ureter, this is bladder, this is prostate, this is urethra. First, we are going to perform what? Cystoscopy. In this case, we are going to perform first cystoscopy, visualization of bladder. After that, we are supposed to perform ureteroscopy, means visualization of ureter. Via ureteroscopy, we can remove the stone, we can break the stone, we can take the biopsy, and we can insert DJ stent, double J stent or ureteric stent. So these are the indications of ureteroscopy. Now see how it's performed. So here you can make out that this is ureteroscope, and this ureteroscope is inserted into the ureter. Now if there is some kind of stone, what will happen? Via Dormia basket, this kind of basket is there. Via Dormia basket, that stone will be removed. So we are going to grasp the stone, we are going to remove it. If the stone is big, we can crack the stone and we can remove the fragments also. Now, again here, depending upon the location of ureteric stone and depending upon the size, treatment options are variable. So see how we manage ureteric stones. Kidney, this is ureter and this is bladder. This is upper one third, this is middle one third, this is lower one third. Now if the stone is in upper one third or middle one third and size is up to 1 centimeter, we can go for ESWL or URS. Preferred is ESWL, and whenever size is more than 1 centimeter, we remove it by URS, that is ureteroscopy. Any stone located in distal one third of ureter removed by URS, that is ureteroscopy. So now have a look of the question. What is the preferred treatment option for 1.5 centimeter stone located in lower third of ureter? So if the stone is located in the lower third of ureter, preferred treatment option is what? It's URS. So ureteroscopy is the preferred treatment option. So correct answer for this question is C. Now see this question. Sheila, middle-aged, diabetic female. So first hint, diabetic female, presented with flank pain and fever. So if there is flank pain and fever, it means there is some infection. Flank means most probably the infection is related to kidney. On ultrasound, kidney was irregular. So here you found that there is some problem or inflammation going on. So inflammation is going on in the kidney. It means patient is having pyelonephritis. Showed fat density lesion with calculi. There is fat density lesion with calculi. What is the diagnosis? It means this patient is having pyelonephritis. What kind of pyelonephritis? There is fat, and because of this, most probably it's xanthogranulomatous, because the hint is there is presence of fat. Second hint, this xanthogranulomatous pyelonephritis is more common in females. Why? Because there is increased risk of one stone. Which stone? Struite stone. Struite stone. So can you see? Middle-aged female, diabetic, presence of stone, fat density lesion. So most probably what's the diagnosis? It's the xanthogranulomatous pyelonephritis. Question is asked, what is the organism responsible for xanthogranulomatous pyelonephritis? And the organism is obviously Proteus, the organism which is responsible for this stone. Lots of questions are asked about cholecystitis and pyelonephritis. We are going to discuss all those questions. First, emphysematous. Emphysematous cholecystitis. The most common organism is Clostridium perfringens or welchii. Perfringens or welchii, followed by E. coli. You know, Clostridium welchii is an anaerobe. E. coli is aerobe. So most common aerobic organism responsible for emphysematous cholecystitis is E. coli. Second, emphysematous. Second, emphysematous pyelonephritis. And for emphysematous pyelonephritis, most common organism responsible is E. coli. Then xanthogranulomatous pyelonephritis, and the most common organism is Proteus. And xanthogranulomatous cholecystitis, it's a non-infectious condition. It's a non-infectious condition caused by rupture of Rokitansky-Ashoff sinuses. Now see this question. 20 years old female presented to emergency with high grade swinging fever. It means there must be some abscess. High grade swinging fever, abdominal tenderness and flank mass. It means this is the abdomen. So what is the problem? There is some flank mass one side and there is fever. There is tenderness. It means here is the pus collection. On CT there was collection around kidney. It means collection around kidney, and there is collection inside kidney. If there is collection or pus inside kidney, this is known as pyonephrosis. Pyonephrosis means kidney is a bag of pus. And in this situation, when the pus is around kidney, it is perinephric abscess. Antibiotics were started. We have to start, but patient condition didn't improve after 48 hours. What's the next best treatment option? Now, I told you one simple logic that in cases of abscess or pus collection anywhere, there is fever with chills and rigor, there is local pain and tenderness. Treatment of choice is what? Incision and drainage with antibiotics. So you are giving antibiotics and patient is not improving. So what we have to go for? We have to go for drainage. Now, deep-seated intra-abdominal abscess is usually drained by ultrasound and CT guided percutaneous aspiration. It is preferred over open drainage. So ultrasound or CT guided percutaneous aspiration is preferred over open drainage. So what is the correct answer here? The correct answer is percutaneous drainage under CT guidance. Why not observation and follow-up? Because patient is not improving. Nephrectomy because kidney function is not impaired. Open surgical drainage, percutaneous drainage is preferred or open drainage. So correct answer for this question is A. Before discussing this question, let us discuss first the important points related to renal tuberculosis. Now, what happens in tuberculosis? The first organ involved or affected is lungs. Now, in renal tuberculosis or in genitourinary tuberculosis, see what's the problem? In genitourinary tuberculosis, first organ is affected in tuberculosis is lungs. After lungs, the genitourinary organs are involved by hematogenous spread. So there is hematogenous spread. Now see how these organs are involved. This is kidney, this is ureter, this is bladder, this is prostate, this is urethra, and this is vas deferens. Now what happens? Via hematogenous spread, two organs are involved. That is kidney and prostate. So via hematogenous spread, there is involvement of kidney and prostate. Rest of the organs are involved by either ascent of infection or descent of infection. Now what is the ascent of infection? Can you see prostate is involved, and after that this infection is going to involve vas deferens, ascent. What is descent of infection? Kidney is involved, via urine the infection reaches ureter and then bladder. So this is descent of infection. In this diagram, you can see that testis is not mentioned. It means testis is usually spared in genitourinary tuberculosis. This is the basic. After that, see the points in the pathogenesis. Now, what happens in tuberculosis? Can you see? This is kidney, this is the minor calyx, this is the major calyx, and this is the pelvis. Now, what is the problem? There is formation of cortical granuloma. These granulomas are usually formed near pyramid. So, formation of cortical granuloma. After that, it is going to enlarge, and there is formation of abscess. This abscess is going to rupture into pelvic calyceal system, and because of rupture into pelvic calyceal system, this pus comes into the pelvic calyceal system, and after that, via urine, it is going out. When the pus is coming in the urine, patient is having increased frequency. This is the earliest, most common symptom. Increased frequency. And when this patient is coming to my OPD with increased frequency, I'm sending urine RM and urine culture and sensitivity. On urine routine and microscopic examination, what is found? There is presence of pus cells. And on urine culture sensitivity, there is no growth within 48 hours. There is no growth within 48 hours. It means what kind of pyuria is this? This is sterile pyuria. So this is sterile pyuria, which is the characteristic feature of tuberculosis. This is just the beginning. After that, there are further sequence of events which are occurring in kidney, ureter, bladder, prostate. Now see what happens in kidney after this. After this, there is stenosis of pelvic-calyceal system or at PUJ. Because of this stenosis, what happens? There is hydronephrosis and pyonephrosis. Actually speaking, pus collection is not there. Actually speaking, there is collection of cheesy material. So there is collection of cheesy material, and kidney is filled with cheesy material that is known as putty kidney. Putty kidney. After that, there is calcification. So there is calcification. Calcified kidney is known as cement kidney. So there is calcified kidney, and this is known as cement kidney. And after calcification, kidney loses its function, and this process is known as autonephrectomy. So this is non-functioning calcified kidney. Non-functioning calcified kidney, this is known as autonephrectomy. So autonephrectomy is seen in renal tuberculosis. Autosplenectomy is seen in sickle cell anemia. These are the sequence of events. After that, how we are going to diagnose the genitourinary tuberculosis, especially the renal tuberculosis. Now see, two questions are there. Investigation of choice for diagnosis of renal tuberculosis is CCT, because it will tell you most of the changes related to the tuberculosis in the kidney. But what this CCT is going to detect advanced features, earliest lesions, that is moth-eaten calyx. The calyceal changes are best picked up by IVP. So second question which is asked, what's the most sensitive investigation to diagnose earliest changes of renal tuberculosis, and that is IVP. Earliest changes of renal tuberculosis are best diagnosed by IVP. Investigation of choice for diagnosis is CCT. Now there are certain other changes. See, in the bladder, earliest change is what? There is pallor around ureteric orifice. So if we perform cystoscopy, there is pallor around ureteric orifice. In advanced cases, the bladder is small contracted. The bladder becomes small and contracted. So there is small contracted bladder. So what? Its lumen is small, capacity is small. So this small contracted bladder in tuberculosis is known as thimble bladder. So this is You can see here the capacity is reduced. So this is thimble bladder. So this is small contracted bladder known as thimble bladder. After that, what are the changes in prostate? Prostate becomes calcified, and because of this calcification, prostate becomes hard. So prostate is hard because of calcification. There are characteristic changes in the vas deferens. Can you see what kind of changes in the vas deferens? Beaded appearance of vas. And what? This is scrotum. Here there is collection of pus. Now this pus will find its own track outside. So what? If you are going to examine the scrotum, there are multiple discharging sinuses via scrotum. So what? Beaded appearance of vas with multiple discharging sinuses via scrotum is characteristic feature of tuberculosis. So these are important questions frequently asked about tuberculosis. Now see the question. Most sensitive imaging modality to detect early renal tuberculosis is IVP, and that is also known as IVU, intravenous urogram. CECT is investigation of choice for diagnosis of renal tuberculosis. It's investigation of choice for diagnosis of renal tuberculosis. So these are the two questions which are frequently asked. A similar question was asked in a latest JIPMER exam. See the question. A 35 years old male came to the hospital with dysuria and pus cells on examination. Pyuria. Dysuria, pyuria. Urine culture was negative. It means obviously there is sterile pyuria. After 5 hours, patient deteriorated suddenly and died due to renal failure. Gross autopsy picture of kidney is shown. Family history of renal disease was present. It means there was family history of renal tuberculosis. Now in this case what you can see that this kidney is having calcification and patient died because of renal failure. Why? Because patient was having non-functioning kidney. So this patient was having non-functioning kidney. Why? Because of this calcification, and this is known as actually autonephrectomy. Autonephrectomy. So what is the cause? In this case, the correct answer is what? Renal tuberculosis. Why not RCC? Because in RCC there is no sterile pyuria. Why not metastasis? Sterile pyuria is not there. Why not cystic renal disease? There might be infection, but sterile pyuria is not there. So the correct answer for this question is C. Now have a look at this question. A 10 years old girl was evaluated for recurrent UTI and dysuria. IVP finding is given below. What is the preferred treatment option? Now see what is this IVP finding showing. In this case you can see that this terminal portion of ureter is dilated. So here you can see that this terminal part of ureter is dilated. It means this is uretrocele. This is uretrocele. So what kind of uretrocele? This is bilateral uretrocele. And what is the name of this finding? Name of this finding is adder head or cobra head appearance. So this is known as adder head or cobra head appearance. Now see the problem. This is kidney, this is ureter, and this is the bladder. This is the ureter. What is the problem? If there is uretrocele, what? There is outflow obstruction. And because of this outflow obstruction, there are back pressure changes. And because of this back pressure changes, what will happen? There is hydrouretronephrosis. So here also you can make out what? That ureter is dilated. Clear? So there is hydrouretronephrosis, evidence of bilateral hydrouretronephrosis. So diagnosis bilateral uretrocele with bilateral hydrouretronephrosis. What is the easiest way to correct this abnormality? Now can you see via urethra I'm going inside and I'm giving incision over the cyst or uretrocele. So if I'm giving incision over the uretrocele, what happens? The obstruction is relieved. So preferred treatment option is endoscopic incision. Now in certain cases this uretrocele is associated with duplication. Now see that situation. This is kidney, this is ureter, this is kidney, This is bladder. Now, if the patient is having duplication, you can see this is upper pole ureter, and this upper pole ureter is opening into the urethra, and this is lower pole ureter. This upper pole ureter is having uretrocele. Because of back pressure changes, sometimes there is hydronephrosis. If there is no function in the upper pole, in that case, what we can go for upper pole nephrectomy. But if there is function in the upper pole, what we do, we are going to excise this ectopic ureter and we are going to re-implant it into the bladder. So this is excision with re-implantation into bladder. So have a look of various treatment options in cases of uretrocele. So in uretrocele, if there is significant upper pole function is there, in that case endoscopic incision or cyst excision with reimplantation. Cyst excision with reimplantation is done. Now, if there is poor upper pole function, in that case upper pole nephrectomy and partial ureterectomy is performed. Upper pole nephrectomy and partial ureterectomy is performed. But be careful, this is situation where there is duplication of ureter. If there is no duplication, preferred treatment is endoscopic incision over the cyst wall. Now see the question. So 10 years old girl evaluated for recurrent UTI and dysuria, IVP findings suggestive of bilateral uretrocele, which is intravesical, means inside the bladder. What is the preferred treatment option? In this case, the preferred treatment option is endoscopic incision. If there is poor upper pole function in cases of duplication, then we go for nephrectomy and partial ureterectomy. What is this sting operation? This is subureteric transurethral injection of Teflon paste, and it is done in duplication of ureter, specially for this lower pole ureter to prevent VUR. And what, there is two techniques for ureteric reimplantation. One is Lich-Gregoire technique and one is Leadbetter Politano technique. These are the treatment options in the patients of VUR. So for this question, what is the correct answer? It is A. Let us discuss important points related to angiomyolipoma first. Angiomyolipoma, it's a benign tumor, consists of angio means matured blood vessel, myo means muscle, and lipoma means fat. So it's a benign disorder composed of matured blood vessel, muscle, and fat. It is more common in females and it is associated with tuberous sclerosis. There are questions which are asked in pathology. 1. It is having positive immunoreactivity for HMB45 and there is presence of macroaneurysm. Macroaneurysm, and this macroaneurysm can be easily detected on angiography. Now, because of presence of macroaneurysm in certain patients, there is increased risk of retroperitoneal hemorrhage. And if there is retroperitoneal hemorrhage occurring, how many patients? 10% patients. This retroperitoneal hemorrhage is known as Wunderlich syndrome. It is known as Wunderlich syndrome. Now, how to make the diagnosis? Let me tell you one simple fact. Whenever there is any mass in the kidney or any tumor in the kidney, our main focus is first to rule out RCC. So how we are going to rule out RCC? With the help of CCT. That's why for most of the renal masses, investigation of choice for diagnosis is CCT. One exception is there, Wilms tumor. In Wilms tumor, for better soft tissue delineation, investigation of choice for diagnosis is MRI. So here, what are the findings which supports the diagnosis of RCC and the findings which are against the diagnosis of RCC? Now, in RCC, there is presence of calcification, and in angiomyolipoma, there is presence of fat. So if we perform CT, presence of fat and absence of calcification is highly suggestive of angiomyolipoma. So now see the question. All of the following statements are correct about angiomyolipoma except associated with tuberous sclerosis, correct. Positive immunoreactivity for HMB45, correct. presence of fat and calcification. No, it's the presence of fat and absence of calcification is diagnostic, and Wunderlich syndrome is seen in 10% patients. So correct answer for this question is C. This is one of the frequently asked question in both radiology as well as surgery. Question: in which conditions central stellate scar is seen on CT scan? Have a look. This is frequently asked question. So central stellate scar is seen in focal nodular hyperplasia seen in liver, fibrolamellar variant of HCC, serous cystadenoma pancreas, and fourth renal oncocytoma. So correct answer for this question is D. Central stellate scar on CT scan is seen in renal oncocytoma, FNH, serous cystadenoma pancreas, as well as fibrolamellar HCC. Now before discussing this question, see the one-liner questions which are asked about RCC. So first question, what is the most common type of RCC? That is clear cell carcinoma. What is the most common type of RCC seen in patients of cystic disease requiring dialysis, or most common type seen in dialysis associated cystic disease? That is papillary carcinoma. Example: suppose a patient is having ADPKD, autosomal dominant polycystic kidney disease. Patient developed renal failure, patient is undergoing hemodialysis for long duration of time, and patient developed the malignancy, that is papillary carcinoma. After that, exclusively associated with sickle cell trait, and that is medullary carcinoma. And which of the following is having best prognosis? It's the chromophobe. There are other questions which are asked. First, this clear cell and papillary, clear cell variant and papillary, both of these are arising from PCT, proximal convoluted tubule, and chromophobe variant, it arises from intercalated cells of collecting duct. It arises from intercalated cells of collecting duct. Second question, this papillary carcinoma, it is associated with dystrophic calcification, and that's known as Samoma bodies. That's known as Samoma bodies. After that, this chromophobe variant of RCC, it is having plant cell appearance. So it's having plant cell appearance. There are multiple chromosome losses with extreme hypodiploidy in chromophobe. After that, gene and chromosomes are asked about clear cell. In clear cell, there is mutation of VHL gene located on chromosome number 3, and usually you are going to see which process. VHL gene located on chromosome number 3, and there are two processes. What? Deletion and translocation. So there is deletion of chromosome number 3, deletion of VHL gene located on chromosome number 3, and there is translocation. In the translocation, there is involvement of two chromosomes. One pair is 36, 38, 311. Papillary is associated with mutation of MET gene located on chromosome number 7, and in this case there is trisomy. So there is trisomy of 7, 16 and 17. 7, 16 and 17. So these are the questions related to RCC. Now see the question. Which of the following combination is incorrect? Most common type of RCC, clear cell carcinoma. Most common type seen with dialysis associated cystic disease, papillary carcinoma. Exclusively associated with sickle cell trait, medullary cell carcinoma, and the best prognosis is seen in chromophobe. Best prognosis is seen in chromophobe. So correct answer for this question is D. Now see, this question is very interesting. Have a look. 55 years old male, age, first clue 55 years. 35 back years, cigarette smoking. There is painless mass in left scrotal sac. Now just imagine this situation. This is kidney, this is renal vein, this is inferior vena cava, this is left renal vein, this is the left gonadal vein, and this is superficial ring. Sorry, this is deep ring, this is superficial ring, and this is the testis. These are the pampiniform plexus of veins. Now, second clue, on laboratory investigation, alpha fetoprotein and lactate dehydrogenase was negative. What is the diagnosis? This question can be easily solved by principle of exclusion. Carcinoma lung is ruled out because no lung related symptoms. Only one thing is in support, that is 35 pack years of cigarette smoking. Otherwise, no other history, no hemoptysis. So what? This is ruled out. Seminoma is ruled out. Why? Age 55 years and smoking is not a risk factor. Alpha fetoprotein LDH tumor markers are negative. It is against testicular tumor. Epididymitis ruled out. Why? Because there is mass in left scrotal sac and there is microscopic hematuria. There is microscopic hematuria. There is no hematuria in epididymitis. So now we are left with RCC. So how we can explain that this is RCC? See, first, smoking is a significant risk factor. Age 55 years. After that, there is microscopic hematuria which is seen in RCC. How we can explain the left scrotal mass? Actually, this is not the mass. Most probably, it's the varicocele. Why? Because RCC is having special property of vascular invasion. Can you see? Whenever there is vascular invasion, because of this vascular invasion, there is increased risk of varicocele. This varicocele can present on any side, either left or right. So whenever this tumor thrombus is reaching IVC and it can lead to IVC obstruction, there is varicocele. Here, before IVC obstruction, when the tumor thrombus is going into renal vein, left renal vein, and what happens after this tumor thrombus? What happens? The drainage of this left gonadal vein is obstructed, so patient will be having what? Varicocele. So the correct answer for this question is C. There are other questions which are frequently asked related to RCC, and those questions are related to paraneoplastic manifestations. Have a look. What are the paraneoplastic manifestations? First, most common paraneoplastic manifestation is raised ESR, seen in 55% cases. Second, there is anemia. Why? Mass replaces kidney, and because of that, there is decreased production of erythropoietin. Third, polycythemia. What's the cause of polycythemia? There is sometimes functional tumor producing erythropoietin, and if there is increased production of erythropoietin, there is polycythemia. Fourth, there is hypertension because of increased production of renin. After that, there is hypercalcemia. Hypercalcemia, and this hypercalcemia is because of increased production of parathyroid hormone related peptide. And sixth, there is Stauffer syndrome. This Stauffer syndrome is because of IL-6, and this is non-metastatic. This is non-metastatic hepatic dysfunction. So this is non-metastatic hepatic dysfunction. Example, sometimes the patients of RCC are going to develop jaundice. If you are going to perform ultrasound abdomen and CT, there is no mass detected in the liver. So what's the cause? Raised IL-6 interleukin 6. This is non-metastatic hepatic dysfunction. It usually resolves after nephrectomy. Out of these, one question is asked, for which of the following paraneoplastic manifestation only medical management is sufficient? So medical management is curative or mainly used for this hypercalcemia. And which agents are used? We are using bisphosphonates, alendronate, palmidronate, zoledronate. So these are the questions related to paraneoplastic manifestations. Now see this question. A 4 years old child, age 4 years, brought to the hospital with complaints of abdominal mass and fever. There is mass and fever. On CT, crescent shaped discrete and peripheral calcification was seen. Abdominal mass, fever. Can you see? Crescent shaped discrete and peripheral calcification is characteristic feature of which tumor? Wilms tumor. It is characteristic feature of Wilms tumor. Now, which of the following chemotherapy regimen is given in this condition? In Wilms tumor, we give Which regimen? VCD. What is this VCD? This is vincristine, cyclophosphamide, vincristine, cyclophosphamide, and doxorubicin or dactinomycin. Doxorubicin or dactinomycin. So these are the agents which are given in Wilms tumor. Lots of questions are asked related to chemotherapy. So we are going to discuss the chemotherapy agents which are used and the chemotherapy regimens which are used in surgery. So you must be knowing that in CA breast we use CAF regimen, cyclophosphamide, adriamycin and 5-fluorouracil. Adriamycin is also known as doxorubicin. After that, hepatoblastoma. In hepatoblastoma, VCF regimen, vincristine, cisplatin and 5-fluorouracil. Carcinoma gallbladder and cholangiocarcinoma regimen is same, that is gemcitabine plus cisplatin. And in carcinoma pancreas, you know that a single drug is given, that is gemcitabine. For carcinoma esophagus and stomach, the regimen is ECF, epirubicin, cisplatin, 5-fluorouracil. Epirubicin, cisplatin, 5-fluorouracil. For small intestinal adenocarcinoma, be careful. Small intestinal adenocarcinoma, we give Folfox. Fol means folinic acid, L means folinic acid or leucovorin, F means 5-fluorouracil, Ox means oxaliplatin. Now, small bowel carcinoid, the regimen is DEF, dacarbazine, epirubicin, 5-fluorouracil. For colorectal cancer, we give Folfox 4. The regimen is Folfox 4. For CA anal canal, it's the Nigro regimen, and that is chemoradiation. In chemotherapy, what we give? 5-fluorouracil plus mitomycin C, and after that, we give radiation. Now, this was the question: Wilms tumor, VCD regimen, vincristine, cyclophosphamide, doxorubicin, or dactinomycin. Carcinoma bladder, this was asked in a latest exam. We give MVAC regimen. MVAC means methotrexate, vinblastine, adriamycin and cisplatin. For rhabdomyosarcoma, VAC regimen. VAC means vincristine, adriamycin and C means cyclophosphamide. Hodgkin's lymphoma and non-Hodgkin's lymphoma is frequently asked. For Hodgkin's lymphoma, we have two regimen, ABVD and MOP. And for non-Hodgkin's lymphoma, we have CHOP. So full form of ABVD, adriamycin, bleomycin, vinblastine and dacarbazine. So this is ABVD. MOP is meclorethamine, oncovin or vincristine, procarbazine, prednisone. And what is this CHOP regimen? This is cyclophosphamide, hydroxydonorubicin or doxorubicin, oncovin or vincristine, and P means prednisone. This list is very important, and almost every year there is one question from this list. Since the question was about Wilms tumor, let us discuss some other important pediatric tumors. First question: what's the most common malignant tumor of infancy? Most common extracranial, be careful, solid tumor in children, and most common abdominal malignancy in children. For all these cases, the answer is neuroblastoma. It's the neuroblastoma. Most common primary malignant renal tumor. Most common primary malignant renal tumor of childhood, it's Wilms tumor. One question is asked: what's the most common renal tumor of infancy? Be careful, it's benign and it's congenital mesoblastic nephroma. What's the most common soft tissue tumor in infants and children? It's rhabdomyosarcoma. What's the most common solid tumor of childhood? It's the brain tumor. And what's the most common cancer of childhood? It's the leukemia followed by brain tumor. These two are most common. Most common cancer of childhood is leukemia followed by brain tumor. Now have a look of this question. All of the following statements are correct about carcinoma renal pelvis except. Now this is kidney. These are the minor calyx. This is the pelvis. This is the ureter. This is the bladder, prostate and urethra. Now let me tell you, Whenever the lining of epithelium is transitional cell, the most common malignancy in that particular organ is transitional cell carcinoma. Now see, in the renal pelvis, in the ureter, in the bladder. In renal pelvis, ureter and bladder, the lining is transitional epithelium, and that's why the most common malignancy in this region is transitional cell carcinoma. Second, the risk factor is common. What? Smoking is a common risk factor for transitional cell carcinoma in this region. Third, the most common symptom is also same. What? Painless hematuria. Now, the problem. In this case, what is the problem? Suppose there is the malignancy. Malignancy in the renal pelvis. In this case, actually, the both proximal and distal segments. What is the problem in this case? There is malignancy. In this case, even the distal part of the ureter is dilated. Why? Because of shedding of malignant cells. And that's why this dilated part, the dilated distal part of ureter is known as goblet sign. And this is better appreciated. This is better appreciated on RGP, that is retrograde pyelogram. Second question, in this case, if we are going to insert the DJ stent, because of this obstruction, what will happen? There is coiling of stent in the distal part, and this coiling is known as Bergman sign. This coiling is known as Bergman sign. Now, how we are going to treat it? Only nephrectomy is not sufficient. So, what we are going to perform is the nephroureterectomy with a small cuff of bladder. So, the treatment, effective treatment is nephroureterectomy with cuff of bladder. Now, see the question. All of the following statements are correct about carcinoma renal pelvis except most common type is transitional cell carcinoma, correct? Painless gross hematuria is the most common symptom, correct? Goblet sign is better appreciated on RGP. This is also correct. Nephrectomy is the treatment of choice. This is partially correct. Correct answer is nephroureterectomy with a cuff of bladder. Now see important questions related to carcinoma renal pelvis. So in carcinoma renal pelvis, the most common symptom is painless gross hematuria. Now diagnosis. We can go for ureteroscopic brush cytology for malignant cells because you know that if the patient is having transitional cell carcinoma, there is shedding of transitional cell. Why? Because the cells are having poorly cohesive nature. So because of this, there is shedding of malignant cells. So that's why even on cytology, transitional cell carcinoma can be diagnosed. If we are going for IVP, we can see radiolucent intraluminal filling defect. Now, generally, what is the investigation of choice? It's CCT or CT urogram. Now, two questions are asked. One is goblet sign and one is Bergman sign. What is this goblet sign? It is characterized by ureteric dilatation below the site of lesion, creating appearance of goblet. And this is better appreciated on retrograde pyelogram. And what is Bergman sign? I told you, when ureteric catheter is passed up to ureter, it may coil distal to ureter. So this is Bergman sign, and I told you the treatment of choices nephroureterectomy with cuff of bladder. Autosomal dominant polycystic kidney disease is very important, so we are going to discuss it in a bit detail. Now, first question, what is the problem in ADPKD? Bilateral kidney is replaced by multiple cysts. Have a look. Now you can see here, bilateral kidney is replaced by multiple cysts. It's autosomal dominant. Two chromosomes are usually involved, 16 and 4. Now what will happen when the bilateral kidney is replaced by the cyst? Over a period of time, renal function starts deteriorating. Now second problem, these cysts are going to compress the vessels of kidney, and because of that there is activation of renin angiotensin system, and because of that there is hypertension. Hypertension is the most common clinical manifestation. In how many patients it is seen? 75% of adults and 25% of children. Hypertension is the most common clinical manifestation of ADPKD. Second, very important point. Most common cause of death is related to hypertension or cardiovascular disorders. So, most common cause of death is related to cardiovascular disorders. What are the complications? In this case, there is increased risk of nephrolithiasis. There is increased risk of infection. Because of nephrolithiasis and infection, there is hematuria. Renal function deteriorates, so there is polyuria. But the specific gravity of urine is low. Questions are asked, what are the various extra-renal manifestations of ADPKD? Frequently asked question. So the extra-renal manifestations of ADPKD, most common is polycystic liver disease. Others are Berry aneurysm, colonic diverticulosis, colonic diverticulosis, mitral valve prolapse, cyst in ovary, pancreas, spleen, cyst in ovary, pancreas, and spleen, cyst in seminal vesicle, and there is arachnoid cyst. Arachnoid cyst. So these are extrarenal manifestations. Most common extrarenal manifestation is polycystic liver disease. One question is asked, in which organ cysts are not seen? It's the lungs. In the lungs, cysts are not seen. In brain, it is seen in 8% cases. Can you see? Arachnoid cyst is there. So in 8% cases, there is arachnoid cyst, but in lungs, it's not seen. In belly, it's wrongly written. After that, what is the investigation of choice for diagnosis? It is CCT. There are certain important signs which are seen on IVP. On IVP, what are the signs seen? On IVP, there is stretching of calyces by cyst, and this stretching of calyces by cyst is known as spider leg or bell like deformity or spider leg appearance. There is bubble appearance because of calyceal distortion, and there is Swiss cheese appearance. These are the signs which are seen on IVP. Now, ultimately, these patients are going to develop what? Renal failure. So, what is the treatment of choice? It's the renal transplantation. The treatment of choice in this condition is renal transplantation. So, have a look of the question. All of the following statements are correct about ADPKD except chromosome affected 16 and 4. Most common cause of death is cardiovascular disorders, spider leg or bell like deformity seen on IVP. Most common clinical feature is hypertension. So correct answer for this question is B.